young patient usually is instability. Middle age is usually impingement and frozen shoulder. Old age is usually arthritis or rotator cuff tear. Okay, so shoulder has got so many different examinations, not possible to do all. So you just tailor it accordingly. Alright, but the front part is all the same. Alright, so I'll show you my template. Alright, so on general inspection, patient is alert, comfortable. Alright, and patient is not on any arm sling or any orthopedic spleen. Alright, so on closer, of course, you need to ask the patient to take down the clothes and all that. Alright, so on closer inspection, again, stability. Alright, no swelling, no scar, no skin changes, and there's no sinus. No wasting of the muscle. Now, what are the wasting that you're looking for? Okay, don't just simply blurt out the word wasting. Alright, I'll tell you. From the front, if there's any wasting, it's a middle head of the deltoid. You've got three heads of the deltoid: anterior, middle, and posterior. So it is the middle that you're looking for. Alright. From the side, you're looking at pectoralis muscle. Any wasting. From the back, you're looking at the supraspinatus fossa, which is here, and your infraspinatus fossa. Supra means above the spine of the scapula. You know, you got the spine of the scapula, which is a prominent, and then here got a depression, and here got a depression. So above is a supraspinatus fossa, below is the infraspinatus fossa. So supraspinatus fossa, you got a supraspinatus muscle. Infraspinatus fossa, you got the infraspinatus and teres minor. Okay? So wasting, you need to know what exactly you're looking for. Middle fiber of the deltoid from the front, sagittally, pectoralis, posteriorly, supraspinatus and infraspinatus fossa. Okay? Then attitude and the alignment of the bilateral upper lip. Is it normal? If it is a dislocated shoulder, they will have externally rotated. They won't be internally rotated. Remember, for shoulder dislocation, they won't be able to touch their opposite shoulder. It's always like that, externally rotated. Alright. For a brachial plexus injury, it will be internally rotated. Okay, alright, so that's the attitude and the alignment. And any obvious bony deformity, like for example, if there's a malunion of the callus, you know, there will be a prominence and so on and so forth. Alright. So then feel tenderness, temperature, no effusion. So temperature, there's no increase in warmth between the bilateral shoulders. Tenderness, palpate from here first. From the sternoclavicular joint, alright, along the clavicle, down to the acromyon and ACJ, alright. Then you can go in front and palpate the coracoid fossa. This is the coracoid fossa, okay, alright. Then palpate behind along the spine of the scapula, okay. Now, if I say I palpate here in front, what am I trying to palpate? Bicipital groove, bicipital tendinitis. Alright. So look, feel, done already. Move. Okay? Move. I'll ask the patient to follow my instructions. I will do together with the patient. Otherwise, raise up, all this, you just give verbal instructions, it's not going to work. Okay. Okay, please stand up. What I need you to do is to do like this. Okay? Hand face, the palm face forward. Okay? And then go slowly, hide up. All the way up. This is what? Abduction. Okay. What is the full range of abduction? Okay, you can put it down.
180.
Okay. A lot of people will say 180, but it's not.
0 to 120.
Until about 170 degrees only. Because if you look at the anatomy, the picture, this will actually be blocked. What? Your head of the humerus will be blocked by your acromyon net. So most likely you'll reach there only. If you reach 180, it's actually you are trying to use your behind the scapulothoracic to actually try to help you. But actually it's not. Okay. Actually the rear glenohumeral is about 170 degrees like that. Okay? And then if you do like that, it's actually using your scapula already. Okay? Alright, so 170. Alright, now there is a tips here. Alright? You can incorporate two things in your shoulder abduction. What is that? If 60 to 120 degrees is painful, it's called? Painful up. Alright, so what does a painful up mean? What does it indicate? Okay, impingement. Impingement. Alright, so let's say you ask the patient to raise. Okay, then now painful, 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 and then after that now okay again. That is called painful arc, 60 to 120 degree, and that is impingement. Alright. Now let's say the patient is able to do smoothly without any pain. But when you ask the patient to bring it down, tiba-tiba drop. What is that called? Drop arm sign, very good. And what does it indicate? Correct. Rotator cuff tear or supraspinatus tear, because the patient is unable to maintain the abduction. Tiba-tiba then drop. Okay? Rotator cuff tear. So you can already incorporate these two things and roughly give you some ideas already. Whether it is a rotator cuff tear or whether it's an impingement from this abduction. Okay? Adduction usually we don't do. Abduction, of course, this one we hardly do. Because it's not very accurate. Okay? Alright. Now, forward flexion. What is the movement of forward flexion? How do you do? Correct. Okay? In front, go all the way up, and then go all the way. This one is extend. Forward flexion and extension. Go towards the back. Okay. Now, internal, external rotation. How do you check? Okay, this is external rotation. Internal? Yes, correct, at the back. Okay, alright. So, of course, internal rotation you can check like this also, but it's not accurate, and then you got tummy and all that, so it's not going to be accurate, alright. So, internal rotation, you do like this. And where should your thumb point at in order to tell that this is normal? Between what level and what level? T1 to T1. T4 to T8. You should be pointing around here, T4 to T8, to indicate that your internal rotation is normal. T4 to T8. Now, some people, they put it here. Okay? They can't. Alright, because of the pain or because of frozen shoulder, they can't. Alright, so T4 to T8. External rotation, yes. So, elbow at the side, about 45 degrees. External rotation. This is internal rotation. Okay, so far understand? So again, for range of motion, shoulder abduction, look for painful arc, look for drop arm sign. Okay, then forward flexion, extension, external rotation, and internal rotation. Okay, so look, few more done already. Usually, I will straight away go and check the rotator cuff muscle weakness, the integrity of each rotator cuff. What are the 4 rotator cuff muscles? Okay, yeah. So SITS, Supraspinatus, Infraspinatus, Teres minor, and Subscapularis. So you're going to check one by one. Usually that's the way I do before I go to any special test for those. So Supraspinatus, how do you check for the weakness of the supraspinatus?
Abduction.
Yes, you can do Jobe test. You can do Jobe test and T-can test. Now, I want to ask you, a lot of people know about Jobe test, but a lot of people do it wrongly. Okay? Now, how would you ask the patient to do Jobe test? How to position the arm? How to position the upper limb? Anybody? Do you usually see what we do like this and after that ask them to do like this? Have you seen before? No. Okay. So, since you also know, then it's good that from the beginning you didn't get it wrong already. Okay, alright. So, the spine of the scapula, if you see here, the shoulder, okay, the shoulder, the spine of the scapula is actually at about 30 degrees, you know. You see, this is 0 degree, this is 30 degrees. Spine of the scapula is about 30 degrees. Understand? Okay? So, when you ask the patient to do Jobe test, it should be at 30 degrees. Okay, you turn like you want to tong iron like that, okay? And then this is 0. This is 30 degrees. Okay? Why? Because, like I said, your supraspinatus muscle comes from your supraspinatus fossa. It is at 30 degree oblique direction like that. So you want to test it fully. You want to isolate that. So you do this. 30 degree. A lot of people misunderstand. A lot of people think that it's 30 degree like this. From this plane 30 degree. It's not. It doesn't make sense. Understand? A lot of people thought that, oh, you want to do Jobe test, you do like this 30 degree and then press. No, it's not. 30 degree is from horizontal. 30 degree up. Because of your spine or the scapula in a 30 degree of this direction, your shoulder is like that. Okay. And why? Because what are the two muscles that allows you to do shoulder abduction? Deltoid and supraspinatus. Okay. So let me explain to you why we need to turn like this. Because you want to eliminate the effect of deltoid. Okay. Because otherwise, if you do this, this can be performed by both supraspinatus and deltoid. But once you do this, the deltoid is not working already. Now this is purely by supraspinatus. So if you do any test, it's mainly testing the integrity of your supraspinatus. Understand? Okay, so Jobe test. You face that, and then after that bring 30 degrees, and then you need to go up higher like that. Okay? And then after that, I'm going to ask the patient, don't let me push it down. Okay, alright. Now, two things I'm checking. One is a power. Does the patient has got a power? If no, then weakness. For which supraspinatus test. If the patient has got pain, alright, what does it mean? Jobe test positive means impingement syndrome. Okay, alright. So two things you're looking for. This is Jobe test, alright, or anti-can test, the same thing. Then, if there is weakness, there's a supraspinatus test. If there is pain, but where is the pain? This one also very important. When you ask the patient to resist you, and the patient complain of pain. If the pain is at the acromion here, then yeah, it's Jobe test positive, indicate impingement syndrome. But if the pain is somewhere else, here, that's not. Understand? That's got to be specific here. That's Jobe test, to test for your supraspinatus also. Alright? Okay, now, how do you test your infraspinatus? We go one by one, we'll give the counter 4. What does the infraspinatus do? Externally rotate. Okay? So, you want to ask the patient to externally rotate, how do you check? Okay, alright. Yeah, you can do that, alright? So you just put the elbow at the side. Okay? And then, both elbow at the side. And then don't let me push it in. Okay? That is to check for the Teres. That's to check for your infraspinatus. Now, what does the Teres minor do?
Also the same.
External rotation. External rotation. You just look at the location of the muscle. You see, supraspinatus is on top. So what it does is that it allows abduction of the shoulder. Infraspinatus is here. Teres minor is here. It pulls at the posterior aspect. So what it does is that when it contracts, it will turn, externally rotate. Both infraspinatus will externally rotate. Teres minor also will externally rotate. Teres minor is just a very thin muscle, very thin, small muscle. Okay, alright. But this one, you check for teres minor. You want to isolate the function of your teres minor. Have you ever heard of the word Hornblower sign? No, Yes. What is that? How you want to give the instruction to the patient? Bring your hand to your mouth. So you see, I ask all of you, okay, see how you all interpret. Bring your hand to your mouth. How would you position your hand? Okay. Everybody do like this because your teres minor is working. Okay. Now those patients their teres minor are not working. What do? They do like that. Bring your hand to your mouth. You will do like this. Why? Because this function is externally rotate. They cannot do this external rotation. So instead, you ask them to bring their hand to their mouth. You will do like this. This is how they blow the horn or the trumpet or anything. So this is called a Hornblower sign positive. Okay? So you ask the patient to bring your hand to your mouth. You say everybody do this, but this person do this. Alright? So this Hornblower sign positive indicating teres muscle minor weakness. Teres minor muscle weakness. Okay? Understand all so far? Alright. So supraspinatus, infraspinatus, teres minor. Now subscapularis. What is the function of subscapularis? Location is the front, coming to the front here. So what does it do?
Internal rotation.
Internally rotate. Okay? So to make matters worse, alright, it can be further divided into upper subscapularis and lower subscapularis. Okay, so there are two tests you need to do. Upper subscapularis we call a Napoleon sign. Napoleon belly press test. Heard before? Okay. So how do you do Napoleon belly press test?
Press on the belly.
Then foot force.
No, like this. You see? You put like this. And then the elbow, not like that, elbow just at the side. Okay? Alright. Don't let me push it in. Okay? Understand? So when I push at the elbow here, the patient will try to do like this. This function is internal rotation. Okay? And why do they call it Napoleon test? it is not because that the surgeon who described it is the name by Napoleon, but rather the Napoleon always stand like this. You will see the Napoleon, the French emperor, is always stand like this. Napoleon belly press test. Okay, that is for upper subscap. The way I remember is that I always remember Napoleon is like the emperor, is the upper class people. So it indicates upper subscap. The lower subscap is called a Gerber lift-off test. G-E-B-E-R. Okay, alright. So yeah, how do you do a Gerber lift-off test?
Patient the hand.
Correct. Very good. And push against your hand. Okay, alright. So now you do like this. Place here. Okay, alright. Show it there. Press against my hand. Press. Some. Like this.
Don't let him push it in.
Okay, this is lower subscap. This is called a Gerber lift-off test. G-E-B-E-R. Gerber lift-off. Okay, now the other side. Okay, push. Yes. Okay, very good. So this is Gerber lift-off test. This is Napoleon belly press test to show two different things: upper subscap and lower subscap. Different. Okay, then you got Supraspinatus, Infraspinatus, and Teres. So you check all the muscles already. You know what is weak already. Okay? So you know what is weak already. So next, roughly from here, you will be able to know whether it is an impingement or instability or frozen shoulder or rotator cuff test up to this point. Alright. Only then you do the special test. Okay, we do quickly the special test. For impingement, one of the tests that we already performed just now, which is a Jobe test, already performed. If they got a pain localized to their acromion end here, then it will be a Jobe test positive. So one test. But usually, I will try to reconfirm it by doing a Hawkins test. But before Hawkins test, alright. So what you do? Shoulder 90, elbow 90, support here, then you internally rotate. Internally rotate in different directions, like that, in different angle. Okay, and the patient will have pain here. Why? Because you bring the humerus head close to the acromion. Now, okay, when you internally rotate, you impinge your supraspinatus tendon. Understand? So, if the patient has got an impingement syndrome, it will be very painful here. That's Hawkins test. Now, have you heard of Neer sign and Neer test? No, Neer sign and Neer test, alright? Okay, go back and read out about it. So basically, it's just a shoulder forward flexion, and they can't do that. They will have pain. That's Neer sign. Okay? Neer test means that once you inject the local anesthesia of steroids inside the subacromion, now they are able to do it. So that's called Neer test positive. But both are pointing towards impingement syndrome. So, in summary, there are so many tests for impingement syndrome. Jobe's test, another name is called empty-hand test. Another one is Hawkins-Kennedy test. The other two are Neer sign and Neer test. My way of doing it is that, this one I totally forget about it. I'll incorporate my Jobe test during the weakness of the rotator cuff, and I will reconfirm it by doing a Hawkins-Kennedy. That's all I do for impingement. I don't do all these already. Okay, alright. So that's for impingement. Now, for instability of the shoulder. Okay, so you feel that it's a bit unstable, it's a young patient, traumatic or atraumatic also can. You can see the sulcus sign. Sulcus sign, which means that there's a depression between the acromion end and the head of the humerus. Like that. And after that, you can exaggerate it by pulling it down, and after that, it will be even more prominent. The sulcus sign. Alright, the sulcus then. Alright. Then after that, for instability, you do a load and shift test. It's like a drawer test in your knee. Okay? It's called a load and shift test. What you do is that you stabilize the scapula, you hold the humerus, okay, just relax, and then after that you translate it anteriorly and translate it posteriorly. Okay? Now the cutoff point is that if there is more than 30% translation of the humeral head anteriorly, it's positive. Posteriorly is 50% the cutoff point. Okay, but it's quite vague like how do you determine 30%, how do you determine 50%? Okay. So instability, load and shift test, and sulcus sign. Alright, load and shift, anterior translation more than 30% of the humeral head being translated is positive. Posteriorly is 50% of the humeral head. Okay, now what is shoulder apprehension test? How do you do it?
The patient to lie down.
Okay, lie down also can, but usually just sitting also okay, right?
You can
Okay,
actually
so
shoulder.
90-90. Alright. Because again, most of the time, shoulder dislocation is anterior or posterior?
Anterior.
Anterior. Okay? Okay, just relax. Just bend like this. Okay? So you hold here. Alright? And then here, you stabilize the scapula. And you bring it backwards. So now you are trying to bring the humeral head in front. Okay? If the patient has got instability of the shoulder anteriorly, it will show grimace or trying to stop you from doing that already. The apprehension phase will come up. And after that, you push it back again. Then patient will feel relief. This is a shoulder apprehension test. So for shoulder instability, again, Sulcus sign, load and shift test, and shoulder apprehension. Impingement we have gone through. If there's a rotator cuff test, just now you already check all the 4 rotator cuff and you know which one is which already. Okay. So last, I think is bicipital tendinitis. What are the 2 tests you can check? You've got a bicipital tendinitis. Speed test. Have you heard about the word speed test before? SPEED. So you extend the elbow and supinate. Okay, now you do. Extend the elbow and supinate. One hand placed at the bicipital groove here, where the patient will feel pain. And then don't let me go straight. Go straight. Don't let me push it down. You just have to supinate. Have to supinate. This one have to supinate. Push it down. Patient will feel pain here at the bicipital groove. Why? Because the biceps do elbow flexion and supination. Elbow does flexion and supination, so your position has got to be like that. And then you, against resistance, patient will feel pain here at the bicipital groove. Okay, that's speed test. Yergason test is that you ask the patient to grab the patient's hand, and then after that, you ask the patient to supinate. Open up your hand. Okay, now open up your hand. Don't let me close it. Okay, and then another hand here. The patient will feel pain here. Why? Again, it's the same thing. Because you want to ask the patient to supinate against resistance. So you prone first, you hold it in that position, ask the patient to open up that. That's Yergason test. Yergason. Yergason test. So for bicipital tendinitis, you do a Yergason test, you do a speed test. Impingement, Jobe test, Hawkins Kennedy test. Okay. Rotator cuff test, you do Jobe test, you do external rotation, you do Hornblower sign, then you do Gerber lift off, and you do Napoleon belly press test. Okay, quite a lot, quite a lot of special tests. Okay, go back and read up. And you need to practice more, then you will know. Okay, I think shoulder, that's all. You don't need to ask the patient to walk, alright? But you would like to end the examination by checking the patient's neck and the peripheral vascular examination of the neurovascular examination of the bilateral upper limb. It's good to mention that you want to check the Beighton score of the patient. What is Beighton score?
That's for hyperlaxity.
Yes, correct. So what is the total score? 9. Okay, and positive will be how many and more?
4 and 4.
4 or more. Alright, will be considered the patient has got a hyperlaxity. So number 1 is try to touch the thumb on the forearm. 1. 2, the other side. 3 is the little finger on the forearm. 3, 4. Okay. 5 and 6. Hyperextension of the elbow. So to do this, then it goes down like that. Okay. So 6 already, correct? 1, 2, 3, 4, 5, 6, 7. Ask the patient to touch the feet. The knee has got to be extended. Okay, touch the feet. So if they can touch, 7. Okay, 8 and 9, you look from the side if there's any recurvatum or not. Recurvatum means that this is like this, and then this go like the knee. Okay, 8 and 9. So total score of 9, 4 or more indicates hyperlaxity. Why is it important? Because some of the patients with atraumatic shoulder instability, they could have hyperlaxity. So it's very easily can come up. That's a Beighton score. I mean, it's a good point that you can point it out at the end of the examination. Not very important, but tell the examiner that you're excellent at it. Okay, alright. So that's shoulder.